Well, good afternoon, everybody, and welcome to another exciting Exploring by the Seat of Your Pants broadcast with us. We've got some familiar faces in the crowd today. We've got some newbies, too. So if you are joining us for the first time, we are all about bringing conservation, adventure, and science into classrooms around the world. And you're catching us on a bittersweet day because today marks the end of an epic series that we've had to help start the school year. Now, last year, we partnered with two amazing organizations. Frontiers for Young Minds, which connects scientists with students to write articles that are accessible for everybody. We did an awesome mini-series with them. And then we did a really epic series with the amazing folks at If Then She Can. So this is the greatest platform for showcasing amazing women in STEM in the world. 125 epic ambassadors. So much fun last year. And then over the summer, by fluke, those two groups partnered together, and we just had to get in on the action. So we have been a part of a 10-part awesome series featuring everyone from divers to forest engineers and more. It's been so wild. You can check out the full series there or on our YouTube channel. Lots to explore and discover. Now, earlier today, we had the penultimate program with Lindsay Rustad talking about her amazing work freezing entire forests, as one does. But today we are going to wrap up the series and wrap up our day with a completely new topic for us in the history of exploring by the seat of your pants. And that is MoCap for movement. Biomechanics. Now, biomechanics is one of those science terms that sounds kind of scary and challenging, but we are going to make it accessible today by highlighting how we're basically using video game technology to help improve patient outcomes and heal children and people all across the spectrum. So, with that, I'm going to zip my lip as we've got a lot to explore and discuss today, and I'm going to bring in our amazing friends at Nationwide Children's Hospital, Kirsten and Matthew. Thank you both so much for being here today at the Game Lab with your skeleton friend behind you, and thank you. Take us away. I can't wait to get on and learn a little more.
Excellent. Thank you so much, Jesse, for having us. We're so excited to talk to everyone today about what we do in our lab. So we work at Nationwide Children's Hospital in Columbus, Ohio. My name's Kirsten Tulchin-Francis. I'm the director of the lab. My background's in engineering and biomechanics. And this is Matthew. Introduce yourself.
Yeah, I am the biomechanist / kinesiologist in the lab. So my background is in exercise science and kinesiology, which is kind of the study of just generally how people move.
We are so excited today to talk to you about 3D motion capture, which is something that we do every day in our hospital with patients here at Nationwide. And we're going to start off by just telling you a little bit about what motion capture is, how we use it, and then give you some examples of some research that we've done with it in the past.
So I'll start us off. Jesse already alluded to video games. And when I say three-dimensional motion capture, most people at first don't think they know what it is, but they know it in the sense of video games and movies. So here's an example of somebody wearing all of these little reflective dots. They have this suit on, and here in a little bit, I'll show you some cameras that'll be all around the room that actually see all those little dots. And then they have computer programs which can then animate that person wearing that suit into a character like Gollum from the Lord of the Rings here, or Tom Hanks from the Polar Express, Mark Ruffalo from the Avengers playing the Hulk, or, like I said, video games. So Ezio from the game Assassin's Creed. I can't recall. I think it's just called NHL, hockey. And then Guitar Hero is another example. So a lot of people know motion capture from that, but we use it in a little bit a different way. It's the same technology, but obviously a different use. We use it to help patients. So really, there are more video game studios and movie studios in the world than there are hospitals with these types of technology. So a lot of the innovations in building new systems comes from the demand of this stuff from entertainment. So this is an example of like a movie studio, and I don't exactly know how many cameras they have around the room here, but you see all of these black rails across the room. Each of those have a little camera hanging on it. Maybe they have 70, 80, up to maybe 100 cameras in this room. Our lab has 15. So much smaller, but it's also a much smaller space. So we're not looking at animation. We're doing something called biomechanics. So what is biomechanics? There's a lot of different fields that feed into it. The first one is anatomy. So you have to know how the skeleton is made up, what bones there are to really have a good understanding of how that skeleton is moving, as well as the muscles, because it's the muscles that cause those bones to move. There's physiology. So you need to know not only what bones there are, what muscles there are, but how they do what they do. And then there's mathematics and engineering. So in biomechanics, we're looking at the way that people move kind of from the lens of an engineer looking at maybe the way an engine moves or a robot moves. We're looking at things like forces and angles and something called torque. All of that is encompassed into what we call biomechanics. So I mentioned a couple things that we can look at in biomechanics, and really there are two main groups of things that we can measure. One is called kinematics on the left-hand side of the screen, and that's motion. So we're looking at things like angles. So if I bend my arm here, you can see this is straight, call that maybe 0 degrees, maybe 90 degrees. So we're looking at angles, the speed of which someone's moving. So if you're walking across the playground, for example, versus you're running, how fast did you get from this spot to this spot? Oh, and then maybe distance. So not only how fast were you getting from point A to point B, but how far is it from point A to point B? And then there's kinetics, and these are the forces. So for that, we look at things like the force of gravity pulling down on your body. We look at things called ground reaction forces. If you've taken a science class and you've heard every action, there's an equal and opposite reaction. Those are called ground reaction forces. We look at those. And then I've already mentioned the muscles. Those are what cause the bones to move. They pull on those bones, causing a force, which gives you the movement of you walking across the playground. So when we talk about motion analysis, I've already mentioned three-dimensional motion capture, but there are other ways to do it. First is just observational. So here at this hospital, we might work with patients that have some sort of medical condition which affects their ability to walk or run around with their friends. And we have all of these fancy cameras that I'll get into, but first and foremost, you can just observationally watch them walk and get a lot of good information from that. Kind of a step up from that is 2D or two-dimensional photos and videos. So maybe you take out your phone and record a video, and there are a lot of apps and softwares nowadays which can actually give you some numbers. So it can calculate those things like that joint angle example that I have with my arm bending here. But really, the gold standard, the best way to do it if you have the ability, is three-dimensional motion capture, and that's what we're going to talk about today. So, like I said, we have a bit smaller lab than that big movie studio that I showed you earlier, 15 cameras and hours. And this is a picture of one of our labs. We have 2, soon to be 3, at this hospital. So patients come in, all of these cameras that are around the room, see them walk around with all of these little reflective dots on. So the patient will come in and we will feel their skeleton for very specific spots of the bone. And then we'll put a little marker on that spot, and then the cameras see where that marker is in three-dimensional space to a very, very high degree of accuracy, up to about 1 millimeter. And then this is what it looks like in the software. So this is one of those little markers. It just looks like a dot here floating around. That dot will give us a good bit of information. It'll tell us where that one specific thing is. But to start calculating angles, you need at least 2, and now you can get a line. So you see that here. And then you need a third marker to get three-dimensional motion capture. So I'll give you a little example here. If I have this pen and I kind of point it directly at the camera, you see one little point. You can kind of see where it translates around here. 2, now you can start to get some angles, but you can't really see if I'm twisting the pen that well unless I add another thing on it, and now you can kind of see me rotate it a lot better. And I spoke through it, but if I go back real quick, that's what you see in this video. If it'll play back for me. There we go. I'll let it get to it. We add that third marker on and we create what's called a plane. Now we have 3 dimensions of motion, and you can use that to track any part of the body that you want to mathematically define with those markers. So in this video here in a minute, you'll see somebody's pelvis pop up. There it is.
There it is.
There it is. So now we're seeing where that part of the body is moving in 3 dimensions. Is it twisting this way or this way or this way? I spoke through all my points. 1 marker gives us a point, 2 gives us a line, 3 gives us a plane, and you need 3 to get all 3 dimensions of movement. So this is what it looks like with somebody with all the markers on. So that example was just the pelvis. We want to know completely how somebody moves. So we're going to measure multiple segments at once. And then it really depends on what you're looking at. But I would say the typical marker sets that we use here at Nationwide Children's are about 30 to 40 markers that we're placing on the patient. It might be a little different between patients. Like I said, if I have somebody who has what's called an ACL tear, it's an injury in their knee, I might have a couple more markers around those parts of the body because I'm really interested in the way that their knee is moving. Or if I have a patient that has a condition called scoliosis, which is where they have a curve in their spine, I'm probably going to have more markers on their back because I'm more interested in the way that their back is moving. So it varies a little bit, but we put a full marker set to get a really good idea of the way the whole patient is moving. But then, like I said earlier, we want to know how the bones are moving. So it looks really cool to create those little stick figures by connecting all of the dots together. But really, we want to know what is the skeleton doing underneath, and that's what we're representing. I'll pass it off to Kirsten to talk about some specific things we're doing.
Great. So that was awesome overview, Matthew. So what we're going to do now is just kind of give you a couple of the examples over the next 5 or 10 minutes about how we use this information. So Matthew talked about something called an ACL tear, and this is something that happens quite a bit in athletes. So if you look at this picture here, you'll see the little blue area here. These are ligaments. So ligaments attach bone to bone. Okay, so this is the anterior cruciate ligament and the posterior cruciate ligament, the ACL and PCL. They connect the femur to the tibia, all right? And in some patients, that can get torn. So if we look at the next line here, you'll see here, this is the kind of similar picture. In this one right in front, it's torn completely in half. So this is called an ACL tear, all right? And this ligament typically prevents your tibia from moving too far forward relative to your femur or your thigh. And this happens a lot with what we call non-contact injuries. So a football player or a basketball player jumps up and lands or tries to cut and change directions and they pop their knee. Nobody hit them. They didn't fall down in the ground and that hit them. It's just a non-contact injury. And this happens quite a bit in athletes, and it happens quite a bit in youth athletes too. Actually, I was 15 when I tore my ACL. So that's kind of what got me interested in biomechanics in the first place. So in this ACL, we want to know what can we do to assess A, your risk of tearing your ACL in the first place, and B, how can we determine when you're ready to go back to playing sports after you've had treatment for that? Okay, so this is an example here. I'm going to talk about it in a minute of what we might do. So rather than just walking in the lab, we're going to have them do a bunch of other things. So we're going to have them do, this is called a drop vertical jump. They're standing on a small box. They jump off the box onto the ground, they land, and then they jump up again and land again. So we're looking at what the position of their knee is as they land, okay? So this is what we want to look at. So we can do this visually a little bit, but it's really hard to do everything we need to look at with your eye. So Matthew told us about 3 different ways to analyze motion. And the first one is just with our eyes. What is the problem with that? Well, the problem with that is that lots of these things happen really quickly, and it's really hard to see those quick movements that happen in your knee as you land. So in this picture, this patient is landing and his knee and is straight up over his foot. You can see it looks like a straight line right up to the middle of his chest. All right, so that's a really good landing. He's landing in line. His body hasn't shifted weight side to side, and his knee is right over his foot. If we look at the other side, you can see now he's shifted his body over a lot more. This is starting to turn. So in this picture, you can see his tibia looks straight ahead, but the femur is pretty straight back too, right to his pelvis. On this one, it's out at an angle. That's really hard to see with your eyes if I didn't stop the video and put a picture up, right? So we want to do this with our biomechanics and measure those measurements, the position of the leg, the forces at the knees, to understand exactly what's going on and if you're at risk for injuring your knee when you're playing, or maybe you've already injured it, you've gone through therapy and rehab, and now you're ready to go back on the soccer field Are you ready? That's what we want to look at. So this is another example. Matthew mentioned the ground reaction forces, and that's true. We exert a force on the ground when we walk, and we have an equal and opposite force back up on our bodies. When this person lands right here in the red arrow, in the red circle, it's kind of hard to see, but there's a green line and a yellow line, and they don't overlap. And you can kind of tell over here. You see how this red arrow under the left leg is longer than the red arrow on the right leg? That tells us that the force under the left leg, or the yellow, is actually higher than the force on the right side. That's something we can't see with our eyes. We can see position a little bit, but we can't see those forces. We need our special equipment in the lab to be able to see that asymmetry, the difference between side to side. So what this means is that this person probably had an injury on the right side and is recovering the right side, and they're protecting it by putting their weight on the left side. But what does that mean for the left side? That means now the left side is at greater risk for getting hurt too, because you're not symmetrical anymore. So one of the things they test when you're recovering from an ACL injury is whether or not the left and the right side are doing things the same and equally sharing the weight. And in this case, they're not. So this is one of the things that we look at with our ACL patients. The other thing I mentioned was the trunk and how you move your upper body to control the forces as well. So this is just showing that when you're standing on one leg and you're nice and upright, that force comes right down from the middle of your body straight down. And that's basically your weight and gravity pulling you down to earth, right? But if I shift my body, and I would encourage everyone to try this later. I'm not going to stand up because I can't see if I'm going to be in the picture anymore. But if you stand up and stand on one leg and hold your body nice and upright, you'll feel those muscles on the side of your hip get a little bit sore. If you lean your body over to the side that you're standing on, it makes it a lot easier. And that's because we've moved that force closer. The distance between your hip and that line, or your knee and that line, is a lot smaller when you do that. You move all the way closer, and it makes the demand on your body a lot less. However, in some cases, that's not a good thing. So in this example, she's moved her body over, and now she's made that line, the distance between that force line and her knee, bigger. And in that case, that's a really bad position to be in. It puts a lot of stress on your knee. And this is how you tear an ACL, because that force is way too high. So this is the kind of things that we use biomechanics on in a patient who's an athlete, who's kind of either at risk for injury or is recovering from an injury. The next example I want to look at is how we measure motion of your spine in, again, young athletes. So your spine is this column right here of all these vertebrae that go right down the middle of your back. And normally that is a really nice straight line. Okay, your ribs come off of the spine, and the upper part of your spine called the thorax, or the upper trunk, and the bottom is called the lumbar spine. And normally, if you look at from the front, it's a nice straight line. And if you look from the back, there's a little bit of a curve in the upper part, and then an opposite curve a little bit from the side in the lower part of your spine. Okay. We also look at a condition called scoliosis. Matthew mentioned that earlier, and that's a curvature of the spine. So if you look at this patient, and sorry, there are some measurements on it. I couldn't get those to go away. You can see now the spine's not straight anymore. So you have a curve in the spine at the top, and then you have another curve in the spine at the bottom. And if you look at it from the side, it also doesn't have the same pattern. It's a lot more motion here, or not more curvature in the lower back. If you look really closely, just to point out, why is scoliosis important? So why is it important that your spine is curved like this? What difference does that make? The problem is that look at the rib cage. See how symmetrical the ribs are here? Side to side, they look the same. On this side, you have a lot bigger area on this side and a lot smaller area on this side. What's inside our rib cage, other than our heart? Our lungs. So if your lungs don't have enough space to inflate and bring in air, you can have problems breathing, and that can be some problems later on if your curve gets really bad. So what do they do for this? They need to straighten your spine if your curve is big enough, right? So some of the treatments for that, I'll show you in a moment. But one thing to just note is that scoliosis is a 3D problem. It's not just curve looking from the front. I mentioned it's also changes in the side to side view. And if you were to look down from above, they should all be lined up in a straight line. And you can see they shift over to the side as well. So it's a 3D problem. Our surgeons use 3D printing to print the spine before they do surgery so they can see exactly what they're getting before they go into surgery. So they'll take a spine like this and they'll do surgery. And in doing surgery, they'll put a bunch of screws and rods in. And now look how straight that spine is now. Same patient, just after surgery. So we wanted to know, okay, I have a baseball player or a softball player. Can they still throw a ball and hit a ball the same after they've had this surgery? Well, let's take a look and see what we can find out. We put markers on the back and we look at the difference between this upper triangle and the middle triangle that tells us upper back motion, the lower back motion, and the total back motion. And now we can say, okay, here's two different patients with two different treatments. This one had that same one I said before. This one had a little bit different. Instead of a metal rod, they put like a rope in there called a tether to hold it in place. If you look at how much motion they have before surgery and how much motion they have after, these two pictures almost look identical. It's actually not the same time. It's before and after, but this person can't bend as much. So the rods limit motion more. So there are pros and cons to each treatment, but we wanted to measure how much it changes with one treatment versus another. Now, we said we wanted to do this in athletes. So what can we do? We can do baseball and softball. So we'll throw them a ball in the lab. We have a real bat, a real ball, we have a big net so they don't hit our cameras. And they'll swing the bat and they'll hit the ball. And we can look at just how much their spine's moving through that process. We also can do golf swings. We can do tennis, forearm serving. We can do pretty much any sport you can think of. We can do dance. So this is a really interesting one too, where they can get a lot of motion in the lower back when they do the jump at the bottom. Now, where does this take us to the future? Just to kind of wrap up what we do lots of things in the lab, but nowadays, lots of people have sensors that they wear. Your phone has sensors. Your watch has sensors. And lots of these are available. Now, they're not all good enough as our lab. Our lab is still the gold standard, but there are some devices out there that you can wear now. It all depends on what you want to know. They have goggles that can track your eyes. We have clothing that you can wear that can tell us your heart rate and your movement. Watches, sensors in your socks, socks or shoes. You name it, they've pretty much already come up with it. So the question is, from a research standpoint, what do we want to know and what sensors can we use in combination with what we do in the lab to track movement? We said earlier, Matthew told us about 2D motion. That's just with your phone. Take your phone out, record it, download these apps that are free now, and it can try to do an estimate. I can tell you, look at his elbow. That dot that was automatically created by the software is not quite on his elbow. So this is not perfect. Again, it's a good overall picture, but it doesn't give us as detailed information as we can get with the 3D capture. But the most exciting thing for us in the 3D motion capture world is what we call markerless. It doesn't involve all of those dots. And this is a new area that's just being tested, where now you can do the same thing by having 8 to 10 cameras around the room, but it doesn't require all the dots, what makes our jobs a lot easier. So that's kind of an overview of everything you need to know about motion capture. This is just another example of that. Again, it's not always correct. It kind of can get a little messed up sometimes, a little confused. But our take-home message is we have lots of different people in our lab. We have engineers, therapists, doctors, biomechanists, and we all work together to understand how our bodies move, how to get kids back out on the playground, and that we really, really believe that motion capture is a great way to help doctors provide the best possible care to their patients. I'm so excited to have gotten to share what we do with you today, and we'd love to answer questions.
Fantastic. Well, thank you both so much. And what neat research. And again, something that we've never covered here at Exploring by the Seat of Your Pants. So really appreciate the chance to feature some new stuff. If you can't see me, feel free to come out a screen share so you can see us as we dive in with Q&A. One of the first questions, just a really easy one, we get this all the time, is there a favorite part of your job? Is there something that really just jumps out every day in the work that you do that you absolutely adore?
Well, for me, it's getting to work with patients, right? So my background is engineering, and you don't usually think about engineers working directly with patients in a healthcare environment, but getting to work with patients, getting to see a patient come in, we give them information about how the best treatments would be for that patient. The doctor goes and does a treatment, the patient comes back, and we see a positive change. That's what we're here for, right? And that gives me goosebumps to think about it. I just love what we do.
Yeah, I first and foremost have to echo Dr. Tulchin-Francis that you see a patient before some sort of treatment, whether that's surgery or maybe a new physical therapy program, and they come back and having used some of the information that you gave them, they now are better at walking or whatever sport they play. That's incredibly rewarding. But to give another side of it, if it's the new things that you can learn from research. So if you want, it's something that you normally measure, you want to figure out a new way to measure that, then having a part in that development of new ways to do things is also incredibly rewarding.
I bet. Lucky you guys. And I love the clinical approach. It's not very often that we have people that are actually involved in medicine and it's just universally, it's so nice talking to people that get to heal people because they're the most passionate people we ever run across. So thanks for that, guys. Question about how the technology has changed. It looks very technical. It looks very sciencey. In the last 10 years, how have we shifted how we do this, or have we?
Yeah, so I would say the biggest thing is that the markers have gotten a lot smaller. When I first started doing this a long time ago, more than 10 years ago, the markers that we put on those patients were the size of ping pong balls. They were huge. And now we can get little itty bitty ones that are like a quarter of a centimeter, really small. We can put lots more of them on. The technology and the cameras, just like the cameras that you have every day, the megapixels, the resolution of those cameras has improved, which means our data is even more accurate. So and then on the software side, things are now more automated. You have machine learning and AI that can come into play that can help automate processes and make things run a lot smoother and more efficient.
Very cool. You actually talked about AI very briefly there, but we do have a question specifically about that, and this comes up in a lot of things like this. Is there any specifics you can share about how AI would help you in the work that you do, or no?
Oh, yeah. So the markerless motion capture, the second to last slide there, that uses all artificial intelligence. So you just feed in literally tens of thousands of videos of people walking and that they have kind of done their initial, like clicking the dots, if you will, to generate an AI-based algorithm. And then when we record a video, it tries to match that to what it's done. So that is really going to be the wave of the future. You know, my biggest thing right now is we're not quite there yet. It's still undergoing the process of developing and getting to the point where we can use it for clinical care. Right now, I would say it's predominantly only used for research at this point.
Okay, thank you for the detail. It's neat. Again, with AI for our students' sake, I mean, a lot of AI technologies are in their infancy. They're just starting off. So how researchers, how people like the Nationwide Children's Hospital team are going to use them are very much in flux over the next years to come. So we'll have to have you guys back and you can tell us how much you're using it in 2026. We had a question about injuries. Do you have any different injuries than you used to get? Is it the same injuries that you've been consistently seeing for years? You talked about the ACL tear in great detail, but are there any changes to the patients that you're getting, or no?
Yeah, absolutely. I think that, there's been not we as in he and I, we as in the biomechanics community have done a lot of research. ACL is a big one. I think that one, especially in kids, is one of the biggest areas of research in sports. And I think there's been a lot of work that have shown that the right type of prehab, in other words, the right type of training on your elite soccer clubs and making sure that they are looking at doing multifaceted training, meaning strength training and running and muscle strength. That's really important to reduce injury. Proper biomechanics, training coaches to see bad biomechanics is an important thing. And that's shown a big reduction in ACL injuries. The problem is they still happen, right? So unfortunately.
We got to be there to fix them when they do. And I love that you mentioned this in terms of, what was the phrase you used? So sorry, man, it was right in my head. Prehab. There we go. Yes. So like for me, I've had to go to physio once in my life, and the solution to the weakness that I had in my leg was strength. It was squats, it was lunges, it was things that built up the muscles and built up the bone and made it all as stable as possible. And I haven't been injured in many years. So that's something just kids, none of you are probably injured, or most of you are not, because when you're young, you can fall, and it's not great things the way people that are older can. But the more you work on strength training, the more equipped you'll be to not ever have to head to the game lab, because you'll be hunky-dory and even better.
Exactly.
We had a question about who you get to work with in this role. So you talked about the larger biomechanics community. Do you get to partner with international scientists? Are you going across the U.S.? Anything you can share about what it's like to work in a field like yours?
Yeah, so I'll comment on that a little bit. I'll start with just here at this hospital. Kirsten already said that we work with therapists, with doctors, with people who are specialized in making braces if somebody needs something for their ankle, maybe. So it's a very multidisciplinary field that we work in, but also, especially on the research side of things, collaboration is a very big effort to develop, new ways to treat or new ways to look at something. So maybe our hospital has a research project and we're looking at something with like the ACLs or the scoliosis patients. And then there are other hospitals around the country that are using the same technology, the same placement of all of those markers, measuring the same things. And then we can get so much more data that way than just maybe what we could do here by ourselves. So collaboration is a very, very big thing.
Just a quick question, because I like talking about the international approach a little bit. Are there are you the most cutting edge lab in the world? Are there other people that are doing things that like no one else is doing, totally different approaches? Or is it sort of a standard of practice that you see sort of replicated across hospitals and centers like yours around the world?
I would say that the equipment that we're using is definitely the top of the line equipment that in the lab. It is used around the world. I've been to labs in Australia. I've been to labs in Europe. I've been to labs all across the US and North America. And many of us have the same kind of technology and are doing the same thing. There's just not a lot of us, I would say. I would say in academic, like hospital settings in the United States like this, especially in kids, less than 30, maybe 40 at most in the entire country. But they are all over the world, Asia, everywhere.
Must be so cool to get to be involved in something like that, where there are so few of you and everything you do is sort of pushing the envelope a little bit further. How neat is that?
Yes, absolutely.
We had a question about what your day-by-day work is like. So like when you wake up in the morning, is it the same day every day? Is it something different every day? What? Yeah, I'm leading in with that perhaps, because I know that was the case. So tell us a little bit about what day-by-day work looks like.
Yeah, so there's a lot of diversity because of, one, the amount of diversity that we see in the patients that we serve. So I'll speak to that first. We've talked about ACLs and we've talked about scoliosis, but we see a lot of other types of patients with different conditions. So exactly what their diagnosis is, or maybe what our research question will dictate exactly what we do with them. But it could be anything from walking to running to doing dance or bending their trunk if they have scoliosis. So that gives a lot of variety in my day just with the patient population that I'm working with. But when I'm not with the patients, there are a lot of other things that we do. So we have obviously a passion for education. We teach lectures to our students here every week. We have to process all of that data too. So we collect it, we put the markers on, the cameras take the little video, but there's a lot of math, like I mentioned, and a lot of engineering that goes in after the fact that the patient doesn't see to get those numbers, those angles, those forces out to actually give to the doctor. So that's a little bit about what the day-to-day could look like.
Very, very cool. Kirsten, anything to add? That was a great answer, but I didn't know if you had anything you wanted to share too.
Yeah, now that I'm more administrative, I answer a lot of emails. No, I'm writing grants. I'm writing manuscripts. We do this research and we want to share it with this whole medical community, right? So a lot of my job is writing manuscripts and getting them out, going and giving presentations at conferences, networking and meeting other collaborators around the world. So my day-to-day is a little bit different than Matthew's, but I think it's just they're different roles.
Very cool. Thank you for that, guys. You guys are fantastic. This has been so much fun. Time flies and you're having fun. We are going to take just two more questions before we wrap up together. One is about if there are big limitations to the work that you do. Are there things you can't heal? Are there certain problems that you just were not there yet, but we're really seeking as the next cutting edge in science in that 2026 time when we can bring you back to talk about it? Anything that jumps to mind?
The one biggest limitation to what we do, and Matthew did a great job of explaining how we have to put 3 markers on every part of the body. So if you think about your foot, you've got like 20 plus 26 bones in your foot. I can't put 3 markers on every bone. So just like with the spine, you didn't see a little triangle on every single vertebral body down that spine, every block. We did it in regions. So that's the biggest limitation, is we don't get down to that little micro level. We're looking more at the motion of certain segments of the body. And that's our biggest limitation. The markerless motion capture has a lot more opportunity, I say, to get a little bit more detailed information because it doesn't involve the markers. The caveat to that is all of the computer programming that goes into those AI models and the algorithms. And that's where we'll be in the future, hopefully.
Well, on the marker note too, like you mentioned how much smaller they've gotten. Are we getting them smaller and smaller? I don't honestly, is there like a technical limit to that we're going to hit? Or in the future, could we have 36 markers on each bone of the foot? What's the deal?
That would be too time consuming to put on. I think the biggest thing there is just that the resolution of the cameras. I mean, think about the camera on your cell phone. It's only so many megapixels per square inch or whatever. And that's the limitation of what we can do.
Okay. Thank you.
And I'll just comment on that too about the size of the markers. There's something with our scoliosis patients that we were trying to do, or track more parts of the spine. So she mentioned putting markers on every single vertebral body. Not quite that, but we wanted more of those little triangles. And those got as small as, I think, 4 millimeters a piece. Mm-hmm. And the cameras track them pretty well.
Very cool.
We can get pretty small.
It's crazy small. It's hard to fathom, really. I mean, you gave some good analogies in the early part of the talk. So thank you very much for that. And there you go. More, better healing in the future, everybody. Before we wrap up and say farewell, I just want to see if there's any last message you want to share about your work, how people can find out more, anything to leave them with today. And when we're done, do stick around after we're done the live broadcast so you and I can chat. But let us know. Anything to leave us with today?
Want to go first and I'll go last?
Sure. I think one of the biggest things, and we've already commented on it, is just how interdisciplinary our team is. I think that we get to do something that's very cool. We mentioned there's maybe 30 of our types of labs in the country. So it's very limited, but you can plug into this type of work from so many different types of education and backgrounds. Like Kirsten, like she said, is an engineer. I'm a kinesiologist. We work with doctors, therapists. So though we are pretty specialized, there's a lot of different professions that we work with.
Nice.
And I'll just end by saying, find what you're passionate about. So I mentioned I tore my ACL when I was 15. I was a huge athlete. I played soccer. I played basketball. I tore my ACL. I had to wear a big brace that didn't fit me right. I said, I'm going to make a better brace. That's how I got into engineering. And so my career and my life has come full circle. Like I got hurt playing a sport. I hurt my ACL, and now I'm doing ACL research to try to prevent other people. I merged my passion for sports and activity with science and engineering and STEM. And that's how I love my job every day. And if you don't love what you do, you're never going to succeed.
No better message than that. What a fantastic wrap up, you two. I just want to note for anyone tuning in at home too, do check out the entire If Then series. You've got so much there. It's all on our YouTube channel. And I really can't encourage our class enough. Whether you want to read amazing articles from scientists like these two, sharing their work in an accessible way, kids.frontiersin.org, and check out ifthenshecan.org too for so much more learning. Matthew, Kirsten, thank you so much for joining us today. We really appreciate your time, passion, expertise, all of it. And for now, we'll wrap up our broadcast. Farewell and have a wonderful rest of your day.